Good day everyone, this is BSN3B Group 5 of NCM 116RLE5F presenting care of clients with problems in nutrition, gastrointestinal, metabolism and endocrine, perception and coordination, facilitated by Ms. Janelyn Ortiz. Here are the course learning outcome for neurovascular assessment. CLO number 1 define the following: neurovascular assessment, compartment syndrome, and paresthesia. For CLO number 2, identify the purpose of neurovascular assessment, and CLO number 3, discuss neurovascular assessment as to its indications, parameters and method of exam and interpretation of results, guidelines, normal and abnormal findings. For pupillary assessment, CLO number 1 define the following: direct light reflex, concentric light reflex, and anisocoria. CLO number 2 discuss briefly the physiology of pupillary reactions. And CLO number 3 present the purpose of pupillary assessment. And CLO number 4 explain pupillary assessment as to its indications, guidelines, normal and abnormal findings. For Glasgow Coma Scale Assessment, CLO number 1 define the following terms: aphasia, apraxia, decerebrate, and decorticate. CLO number 2 present the purpose of Glasgow Coma Scale Assessment. CLO number 3 describe the different levels of consciousness. And CLO number 4 discuss Glasgow Coma Scale Assessment as to its indications, limitations, normal and abnormal findings, and differentiate adult Glasgow Coma Scale to pediatric Glasgow Coma Scale. And finally, the course learning outcome for cranial nerve assessment, CLO number 1 define the following terms: anosmia, hyposmia, agnosia, stereognosis, ptosis, and nystagmus. For CLO number 2, identify the purpose of cranial nerve assessment, and CLO number 3 discuss cranial nerve assessment as to its indications, contraindications, and normal and abnormal findings. So here are the group members: Caballas Nathalie Ann, Cayude Riza Angeli, Detchos Jeremy, Del Rosario Venus Joy, Durano Rolly Joy, and Espinoza Tristan Kyle. Good day everyone, this is Ms. Caballas Nathalie Ann, and together with Ms. Cayude Riza Angeli, we are going to discuss the neurovascular assessment. For CLO number 1, we have the definition of terms. So first, we have the neurovascular assessment. It is an assessment of the status of an affected extremity in terms of the sensory and motor function or neurological aspect, the peripheral circulation or vascular aspect, which pertains to the blood vessels and adequate blood flow to extremity, and comparison to those of the opposite extremity. There are 5 P's in performing the neurovascular assessment. First, we have the pain. It is the universal symptom for compartment syndrome. It may be related to edema, movement of bone fragments or muscle spasm, and when pressure in the limb compartment rises, pain increases. Next is pallor. It refers to the pink, pale, or cyanotic color of the extremity being assessed. It is important to assess this with temperature. Pale, shiny skin distal to the injury may indicate compartment syndrome, while warm, cyanotic extremity may indicate poor venous return. And next is pulse. Pulses should be compared by rate and quality on both the unaffected and affected sides. Diminished, absent pulse distal to injury may indicate vascular dysfunction and insufficiency. It should be reported immediately to the provider. So first, we have the paresthesia. It is often the first sign of an impending problem. Inadequate circulation to extremity or pins and needles sensation that may include numbness or tingling may be a sign of nerve damage or progressing compartment syndrome. And the last P is the paralysis. It is the late sign of neurovascular damage, and complete inability to move the limb distal to the injury means compartment syndrome, and significant muscle and nerve damage may be present. Now let's move on to compartment syndrome. Compartment syndrome occurs when pressure rises in and around the muscles. The pressure is painful and can be dangerous. Compartment syndrome can limit the flow of blood, oxygen, and nutrients to muscles and nerves. It can cause serious damage and possible death. There are two types of compartment syndrome. First is the acute compartment syndrome. It is usually caused by a bad injury and is a medical emergency that requires urgent treatment. This can permanently damage muscles if not treated. This can lead to disability, paralysis, or even death. Next is the chronic compartment syndrome. It is usually not an emergency. It is also called as exertional since it is often caused by physical exertion such as intense exercise. So for the last item for CLO number 1, we have paresthesia. Paresthesia refers to a burning or prickling sensation that occurs in the hands, arms, legs, or feet but can also happen in other parts of the body. The tingling or numbness, skin crawling, or itchy feeling which occurs without warning is usually painless. And now let's move on to CLO number 2, purpose of the neurovascular assessment. The following are the main purposes of neurovascular assessment with a particular emphasis on the need of early detection and treatment of neurovascular diseases. The examiner will be able to assess the integrity of the peripheral vascular system and adequacy of nerve function, detect signs and symptoms of possible neurovascular compromise early on in the disease progression, and recognize diminished and or inadequate circulation and nerve function to enable one to compose a treatment plan to prevent loss of function, while the patient will be able to avail of early treatment if there are any signs present, prevent further muscle nerve damage, avoid more costly treatment that goes with treatment for conditions discovered late in its course, and lastly, have an improved quality of life with lesser possibility of complications. And now we're on the last CLO for neurovascular assessment. CLO number 3 discussed the neurovascular assessment as to its indications, parameters, and method of exam and interpretation of results, guidelines, and normal and abnormal findings. So for the indications, trauma to the musculoskeletal system in the extremities such as a fracture or a car accident requires a neurovascular examination to identify the severity of the injury and the extent of the damage inflicted by measuring the affected area's sensory, motor, and peripheral functions. Next is post-operative evaluation of patient status. This is to determine if there are nerves that are badly affected due to the operation and or to further assess the affected area. Next is before and after the immobilization device was applied to an affected extremity. This is to examine the function of the affected area and to see if the immobilization device caused compartment syndrome. And lastly, burn patients such as circumferential burns. This is to assess the infected limbs of how much the infection has caused damage to the area and to its function. The parameters and method of exam and interpretation of results according to Schreiber are: first, pulses. Assess upper and lower extremity peripheral pulses bilaterally. Be sure to assess for the presence of pulses distal to any injury. Use a 0 to 4 point scale. 0 means absent and 4 means strong or bounding, noting also if the pulse is weak, diminished, or absent. Use a marker to indicate a pulse palpation site that is difficult to locate. This can help others with their assessment and provide consistency. A manual Doppler scan should be utilized if a pulse palpation site is challenging to find or if the pulse is weak. If palpable pulses are not accessible due to casting, assess all other parameters. And next is poikilothermia. Use the back of your hands to assess the skin bilaterally. Skin is normally warm to touch. Cool skin may indicate inadequate arterial supply, while warm may indicate inadequate venous return. And next is pallor or the skin color. Compare the color of the skin bilaterally. Observe and consider the patient's usual skin tone and any skin conditions while performing the assessment. Cyanosis can be present differently in different skin tone. Pallor or cyanosis may indicate inadequate arterial supply. Dusky, cyanotic, mottled, or purple-black coloration may indicate inadequate venous return. Shiny and pale skin suggesting pressure in the affected area may be a sign of compartment syndrome and requires immediate intervention to prevent vascular compromise that can result in muscle and nerve ischemia. And the next is pain. When pain is identified and treated early, complications can be prevented. This can be caused by sensory nerve damage and or diminished blood flow. Ask the patient to indicate the specific and exact location and to describe the character and intensity of pain using a pain rating scale such as the numerical rating scale and Wong-Baker pain scale. Take note of the location, severity, and areas of radiating pain. Be aware of nonverbal pain cues including grimacing, guarding, tachycardia, and hypotension in sedated patients or those who can verbalize information. To continue, we have paresthesia. Ask the patient about changes in sensation such as tingling, numbness, pressure, or burning. A pressure sensor exam often consists of assessing light touch with a cotton swab and assessing temperature discrimination with warm and cold stimuli. Next is sensation. Ask the patient about changes in sensation such as tingling, numbness, pressure, or burning. A pressure sensor exam often consists of assessing light touch with a cotton swab and assessing temperature discrimination with warm and cold water. Pinprick sensation can be tested using the sharp end of a disposable safety pin. Complaints of numbness or tingling in an extremity should be investigated immediately, with the assessment proximal and distal to the site of injury or surgery, if not precluded by a cast or splint. Nerve involvement, compromised blood flow, or the use of the eyes can alter a patient's sensory function. Next is motor function. Assess range of motion and strength. The patient's ability to perform specific movements is a key indicator of motor function of specific nerves, while loss of function is often a late sign of neurovascular compromise. And lastly, we have the edema. Edema can result from musculoskeletal injury that can contribute to vascular compromise and can cause damage to muscle and nerve tissue. Pre-existing disease processes like heart failure, cirrhosis, or kidney disease can place a patient at increased risk for edema-related complications, while elevating the limb no higher than heart level can help decrease edema. That would be all for my part. Now to continue, we have Ms. Riza Kayudi.
Hello, I am Ms. Riza Angelisa Kayudi, and I will be discussing to you the guidelines of the neurovascular assessment. So here are the guidelines. First, problems with loss of concentration, loss of sensation, or dizziness are usually identified through precise questioning during an interview with the client. And the examiner needs to be always sensitive to the fears of the clients because the client may decline to share important information with the examiner if these fears are not addressed. Next, a mental status is often performed at the beginning of the head-to-toe examination because it provides clues regarding the validity of the subjective information provided by the client. And many of the cranial nerves are evaluated during head, neck, eye, and ear examinations, so always take note of those. Next is before the examination, make sure the client has removed all the clothing and the jewelry and put on the examination gown, and have the client sit comfortably and explain position changes throughout the examination. And always provide adequate rest periods, and if the client is older or physically weak, Divide the examinations into parts to be performed over 2 different time periods, and always explain the actions that the client will be asked to perform, such as counting backward or hop one foot. And since it may seem unusual, but these activities are parts of the comprehensive neurologic examination. Next, we have the normal and abnormal findings in neurovascular assessment. So first, we have your motor and cerebellar systems. So assess the condition and the movement of the muscles, and also their size and symmetry of all the muscle groups. The normal findings would be that there's muscles that are fully developed and symmetric in size. For the abnormal findings, the muscle atrophy may be seen in diseases of the lower motor neurons or muscle disorders. There's also could be a injury of the central spinal cord associated with extremity weakness and the loss of motor function, pain, and temperature seen in anterior cord syndrome. There's also could be the loss of proprioception seen in a posterior cord syndrome. Next is to assess the strength and the tone of all the muscles. The normal findings would be that the relaxed muscles would contract voluntarily and show mild, smooth resistance to passive movement, and all the muscle groups are equally strong against resistance and without placidity, spasticity, or rigidity. For the abnormal, there could be a soft, limp, flaccid muscles that are seen with the lower motor neuron involvement. There is a spastic muscle tone is noted with the involvement of the corticospinal motor tract, and there's the rigid muscles that resist the passive movement and are seen with the abnormalities of the extrapyramidal tract. Next, note any unusual involuntary movements such as fasciculations, tics, or tremors. So obviously, the normal would be that there's no fasciculations, tics, or tremors that are noted. And the abnormal findings would be, yes, the fasciculatations, which is the rapid twitching of the resting muscles and seen in lower motor neuron diseases or fatigue. Tic is that twitching of the face, head, or the shoulders from the stress of neurologic disorders. Unusual bizarre face, tongue, jaw, or lip movements from the chronic psychosis or long-term use of the psychotropic drugs. Next, we have to evaluate the gait and balance of our client. So to assess the gait and balance, ask the client to walk naturally across the room and then note the posture, freedom of movement, symmetry, rhythm, and balance. And then ask the client to walk in heel-to-toe fashion, next on the heels, then on the toes. Then demonstrate the walk first, then stand close by in case the client loses their balance. For the normal findings, the gait is steady, opposite arms are swinging, and then the client maintains balance with tandem walking and walks on heel and toes with little difficulty. As for the abnormal findings, the gait and balance can be affected by disorders of the motor, sensory, and vestibular and cerebellar systems. Therefore, a thorough examination of all the systems is necessary when an uneven or unsteady gait is noted. And uncoordinated or unsteady gait that did not appear with the client's normal walking may become apparent with tandem walking or when walking on heels and toes. Next is to perform the Romberg test. Ask the client to stand erect with arms at side and feet together. Note any unsteadiness or swaying. Then, with the client in the same body position, ask the client to close the eyes for 20 seconds. And again, note any imbalances or swaying. So the normal findings would be that the client would stand erect with minimal swaying with eyes both open and closed. For the abnormal findings, the positive Romberg test is that the client will be seen as they're swaying and moving feet apart to prevent fall in seen with diseases of the posterior columns, vestibular dysfunction, or cerebellar disorders. Next is to assess the client's coordination. So demonstrate the finger to nose test to assess accuracy of movement. Then ask the client to extend and hold arms out to the side with eyes open. Next, say touch the tip of your nose first with your right index finger, then with your left index finger. Repeat this 3 times. Next, ask the client to repeat this movement with eyes closed. For the normal findings, the client will be able to touch their finger to nose with smooth, accurate movement with little hesitation. For the abnormal findings, there would be uncoordinated, jerky movements and inability to touch the nose and may be seen with cerebellar diseases. Next, we have to assess the rapid alternating movements of our client. So have the client sit down, then first ask the client to touch each finger to the thumb and to increase speed as the client progresses. Repeat with the other side as well. Next, ask the client to put the palms of both hands down on both legs, then turn the palms up, then turn the palms down again, and ask the client to increase the speed of it. Then perform the heel chin test, wherein you ask the client to lie down and slide the heel of the right foot down the left shin, and then repeat with the other heel and shin. For the normal findings, the client will be able to touch each finger to the thumb rapidly, and then the client will be able to rapidly turn their palms up and down. Then the client is also able to run each heel smoothly down each shin. For the abnormal findings, the inability to perform rapid alternating movements may be seen with cerebellar diseases, upper neuron weaknesses, or extrapyramidal diseases. For the uncoordinated movements or tremors are the abnormal findings, and they are seen with cerebellar diseases. Then deviation of the heel to one side or the other may be seen in cerebral diseases. Next, we have the sensory systems. So we have to assess the light, touch, pain, and temperature sensation of our client. And for each test, we have to ask the client to close both eyes and tell you what they feel and where they feel it. Scatter the stimuli over the distal and proximal parts of all the extremities and the trunk to cover most of the dermatomes. And it is not necessary to cover the entire body surface unless you identify the abnormal symptoms such as pain, numbness, or tingling. To test the light touch sensation, we have to use a wisp of the cotton to touch the client. And as for to test the pain sensation, you have to use blunt and sharp ends of a safety pin or a paper clip. So the normal findings would be that the client would correctly identify the light touches, and the client will be able to correctly differentiate between the dull and sharp sensation, and to also differentiate the hot and cold temperatures over various body parts. And then, for the abnormal findings, many disorders can alter the person's ability to perceive sensation correctly. And these would include peripheral neuropathies due to diabetes mellitus, folic acid deficiency, and alcoholism, and the lesions of the ascending spinal cord, brainstem, cranial nerves, and cerebral cortex. The client may also report anesthesia, which is the absence of touch sensation, hypoesthesia, which is the decreased sensation to touch, hyperesthesia, which is the increased sensitivity to touch, and analgesia, which is the absence pain sensation, hypalgia, which is the decreased sensitivity to pain, and hyperalgesia, which is the increased sensitivity to pain. To test the vibratory sensation of our client, we have to strike a low-pitched tuning fork on the heel of our hand and hold the base on the distal radius, forefingertip, medium malleolus, and lastly, the tip of the great toe. Then ask the client to indicate what he or she feels and repeat on the other side. For the normal findings, the client will be able to correctly identify the sensation. The abnormal finding is that there is the inability to sense the vibration and may be seen in posterior column diseases or peripheral neuropathy. An example is seen with the diabetes or people who have chronic alcohol abuses. Next, to test the sensitivity to position of our client, we have to ask the client to close both eyes and then hold the client's toe or finger on the lateral side and move it up or down. Ask the client to tell you the direction it is moved. Repeat on the other side as well. So the client will be able to correctly identify the directions of the movement. For the abnormal findings, there is the inability to identify the directions of the movements and may be seen in posterior column diseases or peripheral neuropathy, such as people with diabetes or chronic alcohol abuse as well. So next, we have to assess the tactile discrimination of our client. So remember that the client should have their eyes closed to test this diagnosis. Place the familiar objects such as your quarter, paperclip, or keys in the client's hand and ask the client to identify it, and repeat with another object on the other hand. Next is to test the point location. So briefly touch the client and ask the client to identify the point's touch. And next, to test stereographisthesia. So use a blunt instrument to write a number such as 2, 3, or on the palm of the client's hand. Then ask the client to identify the number and repeat with another number on the other hand. So the normal findings of all these tests is that the client will be able to correctly identify the objects. For the abnormal findings, the client has the inability to correctly identify the objects for this diagnosis, or the area being touched, the number written on the hand, or to discriminate between 2 points or identify areas simultaneously touched may be seen in lesions of the sensory cortex. Next, we have your reflexes. So first, we have to test out the deep tendon reflexes of our client. So position the client in a comfortable sitting position and use the reflex hammer to elicit reflexes. For the normal findings, the normal reflex scores ranges from 1, which would present but decrease, 2, which is normal, and then 3, if there is an increased or brisk but not pathologic movement. For the abnormal findings, absent or markedly decreased hyperoflexia, deep tendon reflexes rated 0 occur when a component of the lower motor neurons reflex arc is impaired, and this may be seen with spinal cord injuries. Markedly hyperactive deep tendon reflexes, which is rated 4, may be seen with lesions of the upper motor neurons and when the higher cortical levels are impaired. And then as for the test for bicep reflex, we have to ask the client to partially bend the arm at the elbow with your palm up, then place your thumb over the biceps tendons and strike with your thumb with the pointed side of the reflex hammer. Repeat on the other side, and this evaluates the function of the spinal levels C5 and C6. So, for the normal findings, the elbow flexes and contracts of the biceps muscles and is seen or felt. Ranges from 1 to 3. Forearm flexes and supinates. Ranges from 1 to 3. For the abnormal findings, there is no response or exaggerated response is abnormal, as this may indicate damages in C5 and C6, and it may also indicate muscle impairment. Next, we have to assess the brachioradialis reflex of our client. So ask the client to flex elbow with palm down and hand resting on the abdomen or lap. Then use the flat side of the reflex hammer to tap the tendon at the radius about 2 inches above the wrist, and then repeat on the other side. For the normal findings, flexion and supination of the forearm is present. For the abnormal findings, there is no response or exaggerated responses, and this may indicate that there is a damage of the C5 and C6, and it may also indicate muscle impairment. Next, we have to test the triceps reflex of our client. So ask the client to hang the arm freely while you support it with your non-dominant hand with the elbow flex. So use the flat side of the reflex hammer to tap the tendon above the olecranon and repeat on the other side, and this evaluates the function of the spinal levels C6, C7, and C8. So the normal findings would be that the elbow would extend and the triceps would contract, ranges from 1 to 3. The abnormal findings would be that there is no response or an exaggerated response, as this may indicate damage to C6, C7, and C8, and it may also indicate muscle impairment. Next, we have to assess the patellar reflex of our client. So we have to ask the client to let both legs hang freely off the side of the examinatory table, and using the flat side of the reflex hammer, tap the patellar tendon, which is located just below the patella, and then repeat on the other side. For the client who cannot sit up, gently flex the knee and strike the patella. This evaluates the function of the spinal levels 2, 13, and L4. For the normal findings, the knee would extend, quadriceps muscles contracts, and ranges from 1 to 3. For the abnormal findings, there's no response or exaggerated responses, as this may indicate damage in L2, L3, and it may also indicate muscle impairment. Next, to test the ankle clonus. So when the other reflexes tests have been hyperactive, place one hand under the knee to support the leg. Then briskly dorsiflex the foot towards the client's head. Repeat on the other side. The normal findings would be that there's no rapid contractions or oscillations of the ankle are elicited. For the abnormal findings, there is that repeated rapid contractions or oscillations of the ankle and calf muscles are seen with lesions of the upper motor neurons. Next is to assess the plantar reflex. So with the end of the reflex hammer or the tongue blade, stroke the lateral aspect of the sole from the heel to the ball of the foot, curving medially across the ball. So repeat on the other side, and that this evaluates the function of the spinal levels L4, L5, S1, and S2. Normal findings would be that there is a flexion of the toes. For the abnormal findings, the toes will fan out for abnormal responses, which would indicate there is a positive Babinski responses, and then this may indicate that there's damage to L4, L5, S1, and S2, or a corticospinal lesion, and it may also indicate muscle impairment. Next, we have to test the abdominal reflex of our client. So we have to lightly stroke the abdomen on each side, above and below the umbilicus, and this would evaluate the function of our spinal levels T8, T9, and T10, with the upper abdominal reflex and spinal levels T10, T11, and T12, with the lower abdominal reflex. The normal findings would be that the abdominal muscles would contract, and then the umbilicus deviates towards the side being stimulated. For the abnormal findings, superficial reflexes may be absent with lower or upper motor neurons lesion. Next is to test the cremasteric reflex in male clients. So we have to lightly stroke the inner aspect of the upper thigh, and this evaluates the function of the spinal levels, your T12, L1, and L2. For the normal findings, the scrotum would elevate on the stimulated side, and for the abnormal finding, there is the absence of reflex and may indicate motor neuron disorder. And lastly, we have your meningeal irritation and inflammation. So if you suspect that the client has meningeal irritation or inflammation from infection or subarachnoid hemorrhage, assess the client's neck mobility. So first, make sure that there is no injury to the cervical vertebrae or cervical cord, and then with the client supine, place your hands behind the patient's head and flex the neck forward until the chin touches the chest if possible. For the normal findings, the neck is supple, and then the client can easily bend head and neck forward. For the abnormal finding, there is a pain in the neck and the resistance to deflection can arise from meningeal inflammation, arthritis, or neck injury. Next is the test for the Brudzinski sign. So, as you flex the neck, watch the hips and knees in reaction to your maneuver. The normal finding would be that the hips and the knees would remain relaxed and motionless. And as for the abnormal finding, there is a pain and flexion of the hips and knees as a positive sign of your Brudzinski signs and suggesting there is a meningeal inflammation. And lastly is the test for the Kernig sign. So flex the client's leg at both the hip and the knee and then straighten the knee. So the normal findings would be that there's no pain felt. Discomfort behind knee during the full extension would occur in many normal people. For the abnormal findings, there is pain and increased resistance to extending the knee are positive Kernig signs. And when the Kernig sign is bilateral, the examiner would suspect that there is a meningeal irritation. And that's it for the neurovascular assessment. Thank you for listening.
Good day, everyone. Papillary assessment reported by Mr. Dichos Jeremy and Mr. Rosario Venus John. Definition of terms: direct light reflex. When constriction occurring in the pupils in response to light exposure, a reflex that controls the diameter of the pupil in response to intensity of light. Next, consensual light reflex. It is response of the pupil to light that enters in the contralateral or opposite of the eye. Example, if the light is shown on the right eye, the left pupil also constrict consent. Anisocoria. It is a condition characterized by unequal pupil sizes. Physiology of the papillary reaction. These papillary reactions are also called as reflexes, are mediated by oculomotor nerve or cranial nerve number 3, wherein these protects or each protect and prevent the damage to the delicate photoreceptors from excessive light. For the papillary constriction reaction, it is innervated by the parasympathetic system. A circular muscle called the sphincter papillae has a task of constriction of the pupils. It all begins at the Edinger-Westphal nucleus when it is simulated by the pretactal nuclei, and the Edinger-Westphal generates action potential through the cranial nerve number 3 fibers, and ultimately synapses at the ciliary ganglion, thus constricting the pupils. And papillary dilation is innervated by the sympathetic system. Dilation is controlled by the dilator papillae. Sympathetic innervation begins at the cortex with the first synapse at the ciliospinal center, and postsynaptic neurons then travel to the superior cervical ganglion, then through the carotid plexus, then to the long ciliary muscles, thus allowing the dilator papillae to dilate the pupil. Both pupils admit that light travels through the visual pathway. If a light focuses on only one eye, the pupil on the certain eye responds to ensure that light indeed for vision can enter, but not too much that the eye damage would result. The other pupil responds in the same manner, and it is called as consensual response. So, purpose of papillary assessment. The purpose of papillary assessment is an important part of neurological test because changes in the size, quality, and reactivity of the pupil can provide vital diagnostic information in a critical ill patient, and to initiate early treatment and corrective procedure if there are signs of disorder present or found during the test.
Hello, my name is Venus Del Rosario, and today I will be reporting CLO number 4 under pupillary assessment, which is to discuss the pupillary assessment as to its indication, guidelines, normal and abnormal findings. First off, we have indications. So, the first indication is for cataract. In patients with cataracts, the pupil often does not dilate as well. This is especially important in patients about to undergo cataract surgery, as the pupils will have to be dilated fully to expose the lens. Next, we have optic neuritis. So, it is the inflammation of the optic nerve. Therefore, pupillary assessment has to be done to evaluate the extent of inflammation. Next is Horner syndrome. This condition affects nerve supply to the eye, and so pupillary assessment can help determine its effects on the pupils. We have suspected brain injury. After a head trauma, it is important to assess whether a brain injury has occurred, and this can be done through pupillary assessment. Fifth one, we have central retinal artery occlusion. So the central retinal artery supplies blood to the optic nerve, which is part of the pathway between the pupils and the brain. Therefore, occlusion of this artery can be detrimental to pupillary function, and pupillary assessment must be done. Next, we have intracranial hemorrhage. So, severe bleeding within the cranium can cause pressure on the brain to build up, which can lead to brain damage. As a result, the pupillary assessment should be done to evaluate brain damage. And lastly, we have conjunctivitis. So, patients with conjunctivitis need to have a pupillary assessment to evaluate the extent of the inflammation and its effects on the accessory eye structures. For the guidelines, so prior to the procedure, first note if the patient has any pre-existing irregularity with the pupils, for example, cataracts, false eye, or previous eye injury. Second, check if there are any pre-existing factors that can cause pupillary dilation, for example, medications including atropine and sympathomimetics and traumatic mydriasis. And third, check if there are any pre-existing factors that can cause pupillary constriction, for example, medications including narcotics and topical beta blockers. Now, during the procedure, first explain the procedure to the patient, even if she or he is unconscious. Second, undertake pre-procedure checks to ascertain if there are any pre-existing irregularities with the patient's eye or factors that can influence pupillary assessment findings. Third, assemble equipment, a pen torch, and the patient's observation chart. Fourth, if possible, dim the overhead light source. Darkened room is ideal, but practically, this will rarely be possible. So dim light will facilitate a better view of the pupils and their reaction to light. Fifth, wash and dry hands. Sixth, adopt a position in front of the patient. Seventh, look into each of the patient's eyes, examining the size of the pupils. In continuation, eighth, we have note the size of each pupil. Ninth, compare the sizes of the pupils. Next, we have to note the shape of each pupil. Next, to compare the shapes of the pupils. Then, after providing prior warnings to the patient, move the torchlight from the side of the head towards the pupil and note any change in pupil size and the speed of the reaction. Then lastly, taking care to avoid shining the light in the other eye, observe whether the opposite pupil also reacts. Then, for the guidelines after the procedure, is to document the findings of the pupillary assessment as per local policy and guidelines, and if necessary, inform the nurse in charge of any changes or abnormalities. Now for the normal and abnormal findings. So we have the assessment, which is to inspect the pupil. For the normal findings, we have the pupil is round with a regular border centered in the iris. Pupils are normally equal in size, which has 3 to 5 mm. An equality in pupil size of less than 0.5 mm occurs in 20% of clients. This condition called anisocoria, which is normal. And for the abnormal findings, we have meiosis. It is characterized by constricted and fixed pupils, possibly a result of narcotic drugs or brain damage. Another abnormalities of the pupil is mydriasis, which is when the pupils are dilated bilaterally. Pupils may or may not have a reaction to light stimulus. And lastly, if the difference in the pupil size changes throughout the pupillary response test, the inequality of size is abnormal. The second assessment we have is test pupillary reaction to light. So the first is the direct response, which is shining the light obliquely into the pupil and asking the client to focus on an object in the distance. Its normal response or findings is that the normal direct pupillary response is constriction. Its abnormal findings is that monocular blindness can be detected, and when light directed into the blind eye results in no response in either pupil. When light is directed into the unaffected eye, both pupils constrict. Next, under the test pupillary reaction to light, we have consensual response. This is shining a light obliquely into one eye and observing the pupillary reaction in the opposite eye. Its normal response is the normal consensual pupillary response is constriction, and its abnormal response is pupils do not react at all to direct and consensual pupillary testing. For the last assessment, we have test accommodation of pupils. Its normal findings is that the normal pupillary response is constriction of the pupils and convergence of the eyes when focusing on a near object. And its abnormal findings is the pupils do not constrict and eyes do not converge. That would be all for my part. Thank you.
Good day, everyone. This is Ms. Dorano, and together with Mr. Espinosa, we are going to discuss the Glasgow Coma Scale. So first off, we have the definition of terms. So first, we have the aphasia. It is a communication disorder that makes it hard to use words and impairs the expression and understanding of language, as well as reading and writing. This results from damage to portions of the brain that are responsible for language. For most people, these areas are on the left side of the brain. Aphasia usually occurs suddenly, often following a stroke or head injury, but may also develop slowly as the result of a brain tumor or a progressive neurological disease. There are three types of aphasia. First, we have the Broca's aphasia or expressive. People with Broca's aphasia have damage that primarily affects the frontal lobe of the brain. Broca's aphasia makes it difficult for a person to express themselves, but they usually are able to understand the language. They are characterized by omitting small words such as is and the. A person with Broca's aphasia may say, walk dog, meaning, I will take the dog for a walk. Another type of aphasia is the Wernicke's aphasia. People with Wernicke's aphasia may speak in long, complete sentences that have no meaning, adding unnecessary words and even creating made-up words. A person with Wernicke's aphasia may say, you know that's muddled Pinkard and that I want to get him around and take care of him like you want before. See that the sentence is long, complete, but it has no meaning and you cannot understand what the person is trying to say. The last type of aphasia is the global aphasia. Individuals with global aphasia have severe communication difficulties and may be extremely limited in their ability to speak or comprehend language. This results from damage to extensive portions of the language areas of the brain. Another definition is apraxia. It is a disorder of the brain and the nervous system in which a person is unable to perform tasks or movements when asked, even though the request or command is understood. They are willing to perform the task. The muscles needed to perform the task work properly. The task may have already been learned. This is caused by a defect in the brain pathways that contain the memory of learned patterns of movement. The patients with apraxia cannot use tools or perform such acts such as tying shoelaces or button shirts, which they can do it before. Next is decerebrate. It is an abnormal body posture that involves the arms and legs being held straight out, the toes being pointed downward, and the head and neck being arched backward. The muscles here are tightened and held rigidly. This type of posturing usually means that there has been a severe damage to the brain. Another type of abnormal posturing is the decorticate posture. This involves holding a certain position without meaning to because of problems in the brain. In this case, the person acts in a certain position even though He doesn't want to because of the problems in his brain. For us to recognize the decorticate abnormal posturing, there are several key details that we need to consider or look. First is the arms will be close to his side and bend at the elbows. The forearms and hands will rest on his chest. The hands may each twist inward at the wrist, with the knuckles facing or touching each other. The fingers may bend inward towards the palms. The legs will be straight. The feet will turn inward to face each other. Next, CLO is the purpose of the Glasgow Coma Scale assessment. The Glasgow Coma Scale is important because it is used to objectively describe the extent of impaired consciousness in all types of acute medical and trauma patients. The scale assesses patients according to three aspects of responsiveness, namely the eye opening, motor, and the verbal responses. Aside from that, it can help us to detect early deterioration in a patient's level of consciousness. This will allow us to act in a timely and effective manner so we can manage the care that we give to our patients. The picture beside is the example of a Glasgow Coma Scale. So we have the behavior, the response, and its corresponding score. Next is we have the different levels of consciousness. So here are the different levels of consciousness. First, we have the alert. It is a state in which a patient is awake, aware, alert, and responsive to stimuli. Second is lethargy and somnolence. It is described as severe drowsiness, listlessness, or no interest in anything, and apathy, accompanied by reduced alertness. A lethargic patient often needs a gentle touch or verbal stimulation to initiate a response. She may also follow some basic commands but is slow to respond. She drifts off again once there is no longer stimulation or she is no longer stimulated. Next, we have obtunded. So obtundation is a reduction in alertness with slow responses to stimuli, requiring repeated stimulation to maintain attention, as well as having prolonged periods of sleep and drowsiness between these periods. In this case, the patient is more difficult to arouse. The responses are delayed and minimal, and she does not appear as to fully wake when stimulated, and she immediately goes back to sleep when she is not stimulated. Next, we have stupor. It is a level of impaired consciousness in which a person only minimally responds to vigorous stimulation, such as pinching the toe or shining a light in the eyes. And lastly, we have coma. It is a state of unresponsiveness even to stimuli.
Hi, I'm Espinosa Tristan Kyle, and for CLO number 4, I'll be discussing the Glasgow Coma Scale assessment as to its indications, guidelines, normal and abnormal findings. For the indications, it is used to describe the general level of consciousness in patients with traumatic brain injury and to define broad categories of head injuries. For the guidelines, the following are important points to note when assessing a patient's level of consciousness using the Glasgow Coma Scale and calculating a GCS. In assessing eye-opening response, if a patient's eyes are closed because of facial fractures, this is recorded as C on the chart. Then observe spontaneous eye opening without any speech or touch, then allocated a score of 4. For eye opening to speech, it is recorded when a patient opens his or her eyes to loud and clear commands. Eye opening to speech is allocated a score of 3. Eye opening to pain is recorded if a patient opens his or her eyes to a painful stimulus. Common methods include fingertip pressure and supraorbital ridge pressure, allocated a score of 2. A recording of none should be made when no response to a painful stimulus is observed. In assessing best verbal response, if a patient has an endotracheal tube or tracheostomy tube, In situ, this is recorded as T under no response and allocated a score of 1. Best verbal response cannot be determined with accuracy if a patient is dysphasic, then it is recorded as D. For orientation, patients must be able to identify who they are, where they are, and the month or the year. If one or more of the above questions are answered incorrectly, the patient is classified as confused. A patient is classified as using inappropriate words when conversational exchange is absent. A patient is classified as using incomprehensible sounds when his or her words and speech cannot be identified. A recording of none should be made when the patient does not respond verbally to verbal or physical stimuli. In assessing best motor response, a patient's ability to obey commands is assessed by asking her or him to grip and let go of the assessor's fingers. Both sides should be assessed. In localizing to pain, localizing is a purposeful response and an indication of better brain function. Supraorbital ridge pressure is considered to be one of the most reliable and effective technique. In the presence of facial fractures or gross eye swelling, pinching the earlobe is more favorable than applying supraorbital ridge pressure. In none, no motor response is recorded when there is no response to a painful stimulus. For pupil responses, pupil size and reaction to light are important neurological observations. Normal pupils are round and equal in size. They have 2 to 5 mm in diameters. Abnormal pupil shapes include ovoid, keyhole, or irregular. For the reaction to light, when light is shown into the eye, the pupil should constrict immediately. The withdrawal of the light should produce an immediate and brisk dilation of the pupil. If the pupil reacts briskly to light, it is documented as positive. If the pupil does not react to light, it is documented as negative. If the pupil is sluggish in response when compared with the other pupil, it is documented as S. For CLO number 4.3, we have the normal and abnormal findings. For best eye response, we have 4 grades. For grade 1, we have no eye opening, and for grade 2, opening to respond to pain, the limbs as above. For grade 3, eye opening in response to any speech, or shout, but not necessarily requesting to open the eyes. For grade 4, we have spontaneous eye opening. For best verbal response, we have 5 grades. For grade 1, no verbal response. For grade 2, incomprehensible speech, like moaning but no words. For infant, inconsolable or agitated. For grade 3, we have inappropriate speech, or random or exclamatory articulated speech but no conversational exchange. For infant, we have inconsistently inconsolable or moaning. For grade 4, we have confused conversations. The patient responds to questions in a conversational manner but some disorientation and confusion. For infant, the infant cries but consolable, inappropriate interactions. For grade 5, we have orientated. The patient knows who he or she is, where he or she is, and what the year, season, and month is. For infant, the infant smiles, orientated to sounds, and follows objects and interacts. For best motor response, we have 6 grades. For grade 1, no response to pain. For grade 2, extensor posturing to pain, or decerebrate posture. For grade 3, abnormal flexor response to pain, like stimulus causes abnormal flexion of the limbs, or decorticate posture. For grade 4, we have withdraws to pain, pulls limb away from painful stimulus, and for the infant, we have withdraws from pain. For grade 5, localizing response to pain, or purposeful movements towards changing painful stimuli, is a localizing response. For the infant, we have withdraws from touch. For grade 6, we have obeying command. The patient does simple things as you ask. For infant, moves spontaneously or purposefully. For CLO number 4.3.1, we have the adult Glasgow Coma Scale. The tables shown below are the normal and abnormal responses and their scores. The total of normal responses should be 15, while abnormal responses is only 3. For CLO number 4.3.2, we have the Pediatric Glasgow Coma Scale. We have here the age range and their normal and abnormal findings. The total for normal findings is still 15, while for abnormal findings is still 3.
Good day once again, everyone. So now let's move on to the last assessment, which is the cranial nerve assessment, to be discussed by Ms. Caballas Natalie Ann and Mr. Detchos Jeremy. For CLO number 1, we have the definition of terms. First, we have the anosmia. Anosmia is the partial or full loss of smell. It can be a temporary or permanent condition. It may be caused by nasal congestion from a cold, allergy, sinus infection, or poor air quality. Next, we have the hyposmia. Hyposmia is the decreased sense of smell or a decreased ability to detect odors through your nose. The difference between hyposmia and anosmia is that hyposmia is when the ability to detect odor is reduced, while anosmia is when a person can't detect odor at all. Now we have agnosia. Agnosia is the lack of ability to distinguish objects through visual, auditory, or touch. Agnosia occurs when the brain experiences damage along certain pathways. These pathways involve sensory processing areas, and these parts of the brain store knowledge and information regarding perception and identification of things. It is usually caused by lesions on the parietal, temporal, or occipital lobes of the brain. Next is stereognosis. Stereognosis is the ability to recognize and identify common objects through tactile manipulation without the use of visual cues. Now let's move on to the next one, which is the ptosis. Ptosis is when the upper eyelid droops over the eye. This may occur due to trauma, age, or various medical disorders. This condition is called unilateral ptosis when it affects only one eye, and bilateral ptosis when it affects both eyes. It may come and go, or it might be permanent. It can be present at birth, where it is known as congenital ptosis, or you can develop it later in life, which is known as acquired ptosis. And lastly, we have nystagmus. Nystagmus is an involuntary rhythmic side-to-side, up and down, or circular motion of the eye that occurs with a variety of conditions. Now let's move on to CLO number 2, which is the purpose of the cranial nerve assessment. So for the purpose of cranial nerve assessment is that this examination may reveal signs of sensory or motor dysfunction that could affect the gait, decreased visual acuity, visual field deficits, or visual neglect may cause a patient to adopt a cautious gait pattern and may contribute to falls.
Good day, everyone. By the way, my name is Mr. Jeremy Detchos, and I'm going to discuss the cranial nerve assessment as to its indication, guidelines, normal and abnormal findings. Let's talk about indication. So, cranial nerve assessment is a part of neurologic examination evaluating 5 areas. Letter A. During a routine physical examination, the routine physical examination provides an avenue for the examiner to fully assess the appearance and function of the body. It also helps the examiner to identify and assess problem early and to decrease long-term complication. Letter B. Following any types of trauma. So trivial head trauma that causes a minor head injury can result in cranial nerve pulses. So some cranial nerves are more sensitive to trauma and swelling, making pulses more possible. Letter C. To follow the progression of the disease. Cranial nerve assessment is frequently done on clients not only with existing cranial nerve disorder but also with potential life-threatening diseases. Examiners assess the cranial nerve status to check whether the condition are worsening or Letter D, if the person has any type of the following complaints: headaches, blurry vision, change in behavior, fatigue, change in balance or coordination, numbness or tingling of the arms or legs, decrease in movement of the arms or legs, injury in the head, back, and neck, fever, seizure, slur speech, weakness, and tremor. For contraindication, letter A, confused and agitated patient, because confused and agitated patient might not came up with accurate answer. Letter B, uncooperative patient, so assessing uncooperative patient takes time and sometimes can cause trouble. Letter C, cranial nerve number 5, testing the corneal reflex should not be performed unless sensory impairment is suspected. So it might be uncomfortable for the patient. And letter D, cranial nerve number 9 and number 10. So testing the gag reflex should not be performed unless bulbar impairment is suspected. So it might be uncomfortable for the patient and it might cause the patient to feel. For the normal and abnormal findings, first is to assess the cranial nerve number 1, the olfactory. So ask the client to clear the nose, to remove any mucus and close the eyes, occlude the nostril, and identify the scented objects such as the coffee or the lemon. So normal findings, client will be able to identify correctly the scent exposed to each nostril, while abnormal findings is inability to smell, neurologic anosmia, or identify the correct scent may indicated congenital, nerve tissue injury due to viral or the upper respiratory infection, olfactory tract, lesion, tumor or lesion of the frontal lobe, and nasal or sinus problem. So presenting on your screen is a sample picture for assessing your cranial nerve number 1. So next assessment is the cranial nerve number 2, the optic. So use of Snellen chart. So normal findings is that the client has a 20/20 vision on the right and left eye. So abnormal findings is a difficulty in reading of the Snellen chart and missing letters. Second is to assist or ask the client to read the newspaper and to assist the near vision. So normal findings is that client reads at 14 inches without difficulty, while abnormal findings is that client will read by holding closer than 14 inches in the myopia or holds print farther away as in presbyopia. Next is to assess the visual field of each eye by confrontation. So normal findings is that full visual fields, and then abnormal findings is that loss of visual fields may be seen in the retinal damage. So presented in your screen is a sample picture of the Snellen chart. So next is the assessment of cranial nerve number 3, the oculomotor, cranial nerve number 4, the trochlear, and cranial nerve number 6, the abducens. So first is to inspect the margin of the eyelids of each eye. So normal findings is that eyelids cover about 2 mm of the iris, and then abnormal findings is that ptosis is seen with a weak eye muscle such as in the myasthenia gravis. And then next is to assess the extraocular movements. So normal findings is that eye moves in the smooth coordinated muscle in all 6 cardinal gazes or 6 fields. While for the abnormal findings is that nystagmus, arrhythmic oscillation of the eyes, there's a cerebellar disorder, there's also a limited eye movement, increased intracranial pressure, and also there's a paralytic strabismus, a paralysis of the cranial nerve number 3, number 4, and number 5. So presented in your screen is a sample picture. Continue. Next is to assess the papillary response to light and accommodation in both eyes. So normal findings is that bilateral illuminated of pupil constrict simultaneously, while for the abnormal findings is that dilated pupils about 6 to 7 mm, cranial nerve number 3 paralysis, there's an Argyll-Robinson pupils, constricted fixed pupil, narcotics abuse, the pots damage, unilaterally dilated pupil, unresponsive to light and accommodation on one eye. Cranial nerve number 3 damage. There is also a constricted pupil or unresponsive to light or accommodation. Next is the cranial nerve number 5, the trigeminal. So first is to test the motor function. Ask the client to clench the teeth while you palpate the temporal and the masseter muscle of the for contraction. So normal findings is that temporal and masseter muscles contracted bilaterally, while for the abnormal findings is that decreased contraction. There is a symmetrical strength in moving the jaw. There is a lesion or injury of cranial nerve number 5. There is pain occur with clenching of the teeth. And next is to assess the sensory function, vary touching of the client's forehead, chin and cheeks and chin with a sharp and dull side of the paper clips. Normal findings: the client will correctly identifies the sharp and dull stimuli and light touch. For the abnormal findings is that inability to feel and correctly identify the facial stimuli. So there's possibly a cranial nerve number 5 lesion. So next is the test for the corneal reflex. So normal findings is that eyelids blink bilaterally, while abnormal findings is an absence of corneal reflex. There may be a CNS or cranial nerve number 5 and cranial nerve number 7 lesion. So presented on your screen is the sample picture for assessing the trigeminal motor function and assessing for the trigeminal sensory function. Next is assessment of the cranial nerve number 7, the facial. So test motor function. Ask the client to smile, frown, and wrinkles forehead, show teeth, pop out cheeks, purse lip, raise eyebrows, close eye tightly against resistance. So for the normal findings, client smiles, frowns, wrinkles forehead, show teeth, pop out cheeks, raises the eyebrows against resistance, and movement are symmetric. For abnormal findings, inability to do the action alongside with the paralysis of the lower part of the face on the affected side, so there may be a Bell's palsy, while paralysis of the lower part of the face on the opposite side. So for the sensory, the assessment for sensory, note, no, it's not. Next assessment is the cranial nerve number 7, the facial. So test for motor function. So ask the client to smile, frown, and wrinkles forehead, show teeth, pop out cheeks, purse lips, raise eyebrows, close eye tightly against resistance. So normal findings: client smiles, frown, wrinkles forehead, show teeth, pop out the cheeks, purse lip, raise eyebrows, and closes eye against resistance. Movement of all these are symmetric. So abnormal findings: inability to do the action alongside with the paralysis of the lower part of the face on the affected side. So there's maybe a Bell's palsy, and paralysis of the lower part of the face on the opposite side. For the test of sensory, not routinely tested. So if it is indicated, touch the anterior 2/3 of the tongue with the moistened applicator. Applicator dip in salt, sugar, or lemon juice. Ask the client to identify the flavor. So in the normal findings, the client identifies the correct flavor, while in the abnormal findings, inability to identify the correct flavor in the anterior 2/3 of the tongue suggests that impairment of cranial nerve number 7. So presented on your screen also is a sample picture for testing the cranial nerve number 7. So next is assessment of cranial nerve number 7, the acoustic and vestibulocochlear. So first assessment is to perform Weber's and Rhine's test on assessing the cochlear or the auditory component of cranial nerve number 8. So for the normal findings, client hears whisper word from 1 to 2 feet. Weber's test, vibration heard equally well on both ears, while on Rhine's test, air conduction is twice as long as bone conduction. For abnormal findings, sensory neural loss, so vibratory sound, lateralized on the good ear, while for sensory neural loss, air conduction is longer than bone conduction but not twice as long, while conductive hearing loss, so bone conduct is longer than air conduction. So presented on your screen is sample pictures of the whispers test. The next assessment is the assessment of cranial nerve number 9, the glossopharyngeal, and cranial nerve number 10, the vagus. So first is for motor. Ask the client to open wide and say ah while you use the tongue depressor on the client's tongue. So for the normal findings, uvula of the soft palate rise bilaterally and symmetrically phonation. While for the abnormal findings, soft palate does not rise, unilateral rising of the deviation of uvula for normal side. Next is to assess for the gag reflex, so touch the posterior pharynx with the tongue depressor. So normal findings is that gag reflex intact, while abnormal findings is absent of gag reflex. Next is to check for the client's ability to swallow by giving them a drink of water. Note the client's voice also. So for the normal findings, client swallows without difficulty, no hoarseness noted. While for the abnormal is there's a dysplasia, hoarseness, and there's a cranial nerve number 9 or number 10 lesion. So next is for the assessment of the cranial nerve 11, so the spinal accessory. So first is to ask the client to shrug shoulder against resistance to assist the trapezius muscle. So for the normal findings, symmetric strong contraction of the trapezius muscle, while for the abnormal findings is symmetric muscle contraction or drooping with paralysis or muscle weakness. Next is to ask the client to turn neck against resistance. First is to the right and next is to the left to assess for the sternocleidomastoid muscle. So for the normal findings is the strong contraction of the sternocleidomastoid muscle on the opposite side of the turn face. For the abnormal findings is that atrophy with the facilation. So presented in your screen is a sample assessment for the cranial nerve number 11. And lastly, for cranial nerve number 12, assessing the hypoglossal. So for the assessment, ask the client to protrude the tongue, move it into the each side against the resistance of the tongue depressor, and then put it back on the mouth. Normal findings is that tongue movement is symmetric and smooth, and bilateral strength is apparent. While for the abnormal findings is that facilation and atrophy of the tongue, deviation of the affected side is seen as unilateral vision, and the sample presented in your screen is a sample picture of assessing the hypoglossal nerve. So if you want to read more about the health assessment, there's an available on our health assessment book that was used during our first year. That's all for my report. Thank you and have a wonderful day.